nutritional know-nothings. Nowhere in medicine are the principles more challenged than in the field of nutrition. Nothing is more important than nutrition for correct and optimal bodily and mental functioning. Yet nothing in medicine generates more heat and less light. Only 28% of medical schools have a formal nutrition curriculum, even fewer than in 1977, when Congress passed the law that created the dietary guidelines and called for more nutrition science in the medical classroom. Now, medical students receive, on average, 19.6 contact hours of nutrition instruction during their 4-year medical school careers, about 0.27% of the time spent in class. How is your doctor supposed to provide nutrition advice if they never learned it in the first place? Apart from rare specialized symposia, for example, the University of Arizona's Integrative Nutrition Annual Symposium, or Tulane University's Health Meets Food Symposium, there are virtually no continuing medical education programs on nutrition that aren't corrupted by industry influence. This includes nutraceutical companies peddling dietary supplements as they're trying to insert themselves between food and medicine. Even more concerning is that this isn't an exclusively American problem. Nutrition is poorly taught around the globe. Predictably, the focus of medical school education is on treatment, drugs, devices, and digging, surgery, because they make money for the physician, big pharma, and med tech. This is why medical school operating costs are underwritten by pharma companies. See Chapter 6. After all, why would your doctor recommend a 10-cent per day dietary supplement or a 50-cent per day vegetable that doesn't need a prescription over a $10 a day pharmaceutical that needs their signature and continued follow-ups? Nutritional epidemiology is fraught with controversy. Recently, there have been calls to curtail nutritional research because it is hard to do properly. For most nutrients, patient recall is the only method for estimating consumption, and people forget, especially about items that they think aren't good for them. Furthermore, analysis of data is always suspect since correlation is not causation. In order to determine causation in research, you need one of two kinds of studies. The first is called randomized controlled trials, RCTs. This is the gold standard for drug evaluation, but nutritional studies can't be controlled very easily because with prospective, following patients over time, studies, it's hard to alter people's diets for any length of time. When one nutrient goes up, for example carbohydrate, another goes down, for example fat. The other kind of study is known as econometric analysis, in which natural history studies of changes in disease rates over time are analyzed, taking into account all other co-occurring factors. This is how we determine that tobacco causes lung cancer, because doing an RCT would get you thrown in jail. Econometric analysis is more conducive to nutritional research, and is how we proved that sugar is causative for type 2 diabetes. Of course, both kinds of studies are complicated to perform, require appropriate statistical analysis, and drive the cost of such projects up. Another reason, as discussed above, is that the food industry has put the thumb on the scale of many nutritional studies, polluting the literature. Last, you have to measure the correct metric, which is difficult, expensive, and time-consuming. For example, biomarkers, for example LDL-C, are not the same as events, for example heart attacks. See Chapter 2. Doctors figure, why bother to try? Patients are notorious for ignoring medical advice, even as it relates to their own longevity. Most can't or won't change their diets, or miraculously start exercising just because their doctor tells them to. Stanford nutritionist Christopher Gardner showed in his A to Z study that all dietary interventions regressed to the mean, meaning by 2 months on any specific diet, the subject will return to eating the same way they were before the intervention. Dieting is hard and rarely works in the long term. You can alter your health, but you have to know why. Your doctor does too. They need to be able to explain the why back to you. One thing I've learned after 40 years in medicine is that if you don't understand and tell people why something will work, they won't do it. You really can't blame the public for their nutritional whiplash. We're exposed to a daily barrage of contradictory statements and straw man arguments about basic science. One day fat is bad, the next day fat is good, coming from physicians and dietitians, while nutritional biochemistry is ignored. In other words, how metabolism works versus calorie counting and body weight. The physicians don't understand it themselves. If there's no science or understanding, there's no imperative to change. Another reason that patients can't or won't alter their diets is that they're abusing sugar, the food additive that's most addictive, induces metabolic disease, and reduces longevity. These patients need help from their doctors more than ever. But doctors understand addiction about as well as they understand nutrition. Witness the doctor's response to our current opioid crisis, where we have 2 million addicted people and only 5,500 physicians trained in addiction medicine. Since there's been perennially so little money for nutrition research, Big Food has stepped in to fill the void. They conduct their own studies, which are 7.36 times more likely to support their own product than not. They pollute the professional journals with biased research so they can point to their own studies and say that a nutritional principle is not settled science. And they use their money to buy the loyalty of dietitians. See Chapter 4. And to co-opt and pay off scientists and critics alike.